So good morning, friends. Welcome to yet another session of Dr. Sahasranam's ECG quiz. I hope you are finding all these sessions very interesting, useful, and also challenging. Today, I'm here with two 12-lead ECGs and one ECG on arrhythmia. I hope you already are ready with your pen and your paper to make a quick diagnosis here. Now, as I said in the last session, it is important if you have a diagram of the hexaxial reference system in front of you when you are answering this quiz so that it helps you to determine the axis quickly. I hope you are also revising the previous sessions of ECG classes which I have taken you, and this will help you solve these ECGs correctly and quickly. We will go on to the first ECG. This is the ECG of a 55-year-old man who was admitted to the cardiac ICU with a chest pain of 5 days duration. Now, simple questions. What is the diagnosis according to the ECG? And what is the axis of the QRS complex in this patient? These are the two important questions. So I think simple question, simple ECG, you would have answered it. Now we'll go on to the answers. So let us look at this ECG. There are a lot of findings here. You can see that the P waves are normal. But looking at the PR interval, it is prolonged slightly. It is about 6.5 to 7 millimeters, the PR interval. So that would work out to go 280 milliseconds roughly, which is more than the normal. So there is a first degree atrioventricular block. Second point, if you look at V1, it shows an RSR prime pattern, which indicates a right bundle branch block. So first degree AV block, right bundle branch block. Now there is a QR pattern in V2 and a QS pattern in V3 and V4 indicating an anterior wall myocardial infarction, right? The ST segment has settled down to the isoelectric line, but the T waves are still inverted. So it can be said to be a recent anterior wall myocardial infarction. Now comes the QRS axis. What is the QRS axis? Lead 1 is positive, lead 3 is negative. So according to our thumb rule, the axis is to the left, isn't it? Lead 1 is positive, and if you invert AVR in your mind, it is negative, isn't it? So the axis would be between 1 and the inverted AVR, which is between 0 degrees and plus 30 degrees. That will work out to be plus 15 degrees. So the transition is at plus 15 degrees. Now you add 90 to plus 15 and you will get minus 75 degrees, which is a very significant left axis deviation, right? What does this tell you? This left axis deviation of minus 75 degrees gives you a diagnosis of left anterior vesicular block. So the full diagnosis in this patient will be first degree AV block, right bundle branch block, left anterior vesicular block or bifasicular block with a recent anterior wall myocardial infarction. Now previously, in previous days, right bundle branch block with left anterior hemi block, which is already bifasicular block, along with first degree AV block, was called a trifasicular disease. But now we are not calling it so, because the first degree AV block is at the AV node, whereas the bundle branch blocks are lower down, right? So we don't call it a trifasicular block anymore. Now this is a continuous strip. Actually, the upper and lower strips are continuous, right? Of lead 2 of a patient who was admitted to the cardiac ICU with an acute chest pain. The panels are continuous, as I said. Now the questions here are, what is the arrhythmia which you are seeing? Second, identify the types of QRS in this strip. There are more than one type of QRS in this rhythm strip. Third is what could be the cause of this arrhythmia, and what is the underlying heart disease which caused the arrhythmia. And then the fourth will be, how will you manage this arrhythmia, or what treatment you will give the patient. So about 2.5 to 3 minutes, right? You can proceed to answer the questions. So friends, I am sure you would have answered the questions correctly. The 4 questions were: what is the arrhythmia? Identify the types of QRS in the given strip. What would be the cause of arrhythmia and the underlying heart disease? And how will you treat this arrhythmia? Now this is lead 2 we said already, isn't it? So the first 3 beats, 1, 2 and 3, these 3 beats show wide QRS complexes occurring at a rate of 60 beats per minute. That is, this RR interval works out to be 5 large divisions. So 300 by 5 works out to be 60 beats per minute, isn't it? So these are not preceded by P waves. Look carefully, there are no P waves in front of these QRS complexes. So a wide QRS coming at a rate of 60 per minute and not preceded by P waves are arising from the below the bundle of His, isn't it? That is the ventricles. So this is a ventricular rhythm. Now, is it an idioventricular rhythm? A normal idioventricular rhythm should beat at 20 to 40 beats per minute, whereas here the rate is 60 beats per minute. So I would call it as an accelerated idioventricular rhythm. Now if you look carefully, these 2 beats, that is the 4th and the 5th beats in the upper panel, show narrow QRS complexes. Not only that, there are P waves coming in front. This P wave is of course falling on the T wave. That is why it is hidden inside the T wave. So P waves are preceding it and they are narrow. What are they? They are simple sinus beats, what you call in this context as capture beats, isn't it? Now look at the 7th and 8th, these 2. This is the 7th and this is the 8th. Now these are strange QRS complexes. They are a hybrid between the ventricular beat and the sinus beat. It looks as if it is a fusion of these 2 beats. That is, you have a P wave preceding it. The QRS looks like the ventricular QRS, but it is narrow like the sinus QRS. So it is having features of both ventricular as well as the sinus beat. This is called the fusion beat. It is also called Dressler's beat. I hope you remember that name, Dressler's beat. We have discussed this before. So in this ECG, you have 3 types of QRS complexes, which are: one is the accelerated idioventricular rhythm. The second is the sinus QRS complex. This is beating at a rate of 75 per minute. There are 4 large squares between these 2 R waves. So it is 75 per minute, which is faster than the idioventricular rhythm. And the third is the fusion beats. Now my question was, what is the underlying heart disease? This is lead 2. And the 2 sinus beats here show this is a slight coving of the QRS can be identified here, and you can see T inversion in these 2 leads, which suggests an inferior wall myocardial infarction, which was acute. It was with this infarction that he was admitted to the cardiac ICU. Now, what caused this arrhythmia? That was my third question. The patient had a thrombolysis with streptokinase, and this ECG was taken after the thrombolysis during the monitoring in the cardiac ICU. Now this ECG was recorded about 30-35 years ago, long ago, before we had the facilities for angioplasty, right? That is why we gave him thrombolysis with streptokinase. Now this is called a reperfusion arrhythmia. Reperfusion, that is when you remove the block just by streptokinase or with angioplasty. What happens is there is a sudden rush of blood into that area. It flushes out a lot of chemicals, or rather metabolites, and that produces this arrhythmia, which is called the reperfusion arrhythmia. Usually it is harmless. Right. What will you do to treat this patient? No treatment is needed for this patient if the patient is having a normal hemodynamics. Blood pressure is normal and the patient is comfortable without any dyspnea or any other symptom. The sinus rate, as I told you, is 75 beats per minute. Now it is intermittently capturing the ventricles, right? So the sinus is present and it is active, but somehow the accelerated idioventricular rhythm is overriding the sinus whenever the sinus rate goes below 60 per minute, right? So simple method will be just you accelerate this sinus rate. And how will you accelerate the sinus? Give a small dose of atropine intravenously. If you give atropine, you can accelerate the sinus rate. That would improve the hemodynamics also if it is impaired. Or what you can do is you can do a pacing. You can put a pacemaker into the ventricle and do a pacing for the patient, which will override the abnormal rhythm and help the patient. So these are the methods. I hope you understood. There were 4 questions here. So we'll go on to the next slide. Well, this was accelerated idioventricular rhythm with sinus capture beats, fusion beats, restless beats, and acute inferior wall myocardial infarction. Now this is the ECG of a 32-year-old female who came to the cardiology outpatient department with a history of dyspnea of 2 years duration. This ECG was taken long ago, 40 years or so, when I was a resident in the department of cardiology. Now, what is the diagnosis from the ECG? That is my first question. My second question is, what would have been the clinical condition, or what is the clinical diagnosis of the patient? What disease produces this ECG change? Okay. So I'm sure that you would have got the diagnosis here. It's a very simple ECG, not much findings either here, right? We'll go on to the answers. So I'm sure you would have answered this. This is a very simple ECG. In the limb leads, lead 1 and lead 2, they show these two, right? Show a broad P wave which is notched at the top, isn't it? In V1, the P wave is inverted and 2 millimeters in depth and width. Now this is the classical P mitral or the M-shaped P wave, which is indicative of a left atrial enlargement. But carefully, you should also look for left ventricular hypertrophy, which is not there in this patient. So a left atrial enlargement without left ventricular hypertrophy. Similarly, if you get a right atrial enlargement in any patient, always look for a right ventricular hypertrophy. So this patient had an isolated left atrial enlargement without left ventricular hypertrophy, and the commonest conditions we encounter clinically in India is always rheumatic mitral stenosis, isn't it? This lady had a tight mitral stenosis which was operated with a mitral commissurotomy, and she was relieved of her symptoms. This was about 30-40 years ago, when we did not have the facilities for the balloon valvotomy which we do today, and hence we had to resort to a surgical commissurotomy. I will be bringing more interesting ECGs as a quiz to you, maybe in a couple of days. So by that time, I hope I shall be sure that you would have revised your previous ECG sessions, and please put your comments below, because I don't find much comments here, and I find that very few messages also are received, either from through your WhatsApp or through mail or so. I assume that this is due to a complete understanding of what I am explaining. I hope so, because if you are not understanding, then you should be asking questions to me. And since you don't ask questions, I assume that you understand whatever I am saying. Well, thank you for that. And kindly share these with your friends, and also subscribe to my channel if you have already not done so. Thank you. Till we meet again. Bye.